Questions 31 to 42. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Now look at Extract 1. Extract 1, questions 31 to 36. You hear an interview with Dr. Christine Erickson, who is talking about her research supporting non-fasting lipid blood tests for cholesterol. You now have 90 seconds to read questions 31 to 36.
Hello and welcome to Health Research Roundup. For decades, people have been asked to fast before having blood tests to check their cholesterol levels. However, a new research report from an international group of experts suggests this might no longer be necessary. To discuss the research, my guest today is Dr. Christine Erickson from Copenhagen University Hospital, one of the lead authors of the study. Christine, welcome.
Thank you very much.
So, why did we ever ask people to fast before blood lipid tests?
Well, if you ask me, I don't really know, except that it's just what we've been doing for so many years. I tried to read through the literature to find scientific evidence supporting that fasting is actually superior to taking a random, non-fasting sample. And honestly, I had trouble finding any strong evidence. There are lots of arguments about fasting versus non-fasting, but solid proof that fasting is better? I couldn't find it.
So would you say it was more of a tradition than actual science?
Yes, I think so. If you ask why it started, I think it's because some of the earliest studies, the original publications, used fasting samples. So everyone just assumed that's how it had to be done. Those early researchers may have had good reasons, but I haven't seen anything that says it must be done that way.
But now there's evidence from other countries too, right?
Yes, definitely. There are excellent studies from Canada and the US, one involving children, another with adults. And we also have a lot of data from Copenhagen. All of it shows that when you take a lipid panel from people who've eaten and drunk as they normally would, the levels don't change that much. You might see a small rise in triglycerides, which is a very common blood fat, but it's minimal.
So, there is a difference?
Yes, technically. It rises by about 0.3 millimoles per liter. But clinically, when we assess triglycerides, we're interested in increases of 1 or 2 millimoles, not 0.3. That's not clinically significant. Even with LDL, the so-called bad cholesterol, the change isn't enough to affect decisions like whether or not someone should start medication.
And you tested this directly?
Yes, we included direct measurements after fasting in about 6,000 people. And honestly, the correlation between fasting and non-fasting results was so strong, you really couldn't tell the difference.
Denmark moved to non-fasting tests officially about 7 years ago, correct?
That's right.
What's happened since then? Any issues with misdiagnosis or poor outcomes?
No issues at all. Everyone was on board quite quickly, even the laboratories. Some of them didn't change immediately, but patients started requesting non-fasting tests because they'd seen the media reports that Copenhagen University Hospital had switched. So, demand actually drove the change. And today, clinicians, labs, patients, everyone's happy.
So patients prefer it?
Absolutely. It's much simpler. People are more likely to go for testing now because they don't need to fast. They can just come in when it's convenient for them. You'd be surprised how many people skip their lipid test just because fasting is such a hassle, especially if they have work or early meetings.
And finally, are there any situations where a fasting lipid test is still necessary?
This recommendation comes from 21 world experts, many from Europe, the US, and one from Australia. And of course, when you have so many experts, some will think there are specific scenarios. We listed a few, like patients with diabetes. In those cases, fasting might be important from a safety perspective, because of issues with blood sugar. But if you ask me personally, deep down, I don't think it's truly necessary.
Turn over and look at Extract 2. Extract 2, questions 37 to 42. You hear a presentation in which a researcher called Dr. Milan Patrician is talking about the relationship between new technology and medicine in the future. You now have 90 seconds to read questions 37 to 42.
Hi, I'm Dr. Milan Patrician, and today I'd like to talk about the future of medicine, particularly in relation to the current technological revolution. For many of us, it seems inevitable that medical robots, automation, and artificial intelligence will replace many jobs in healthcare. Surgical robots are becoming increasingly more precise, and right now, man-sized robots can lift and move patients and transport them throughout a hospital. Silicon Valley investor Vinod Khosla once said, "Technology will replace 80% of doctors, because machines will be more accurate, objective, and cheaper than the average doctor." He added that eventually we won't need doctors at all. However, I disagree. Instead, I think technology in some species will finally allow doctors to focus on what makes them good physicians, treating patients and innovating, while automation does the repetitive part of the work. So let's look at some examples of how different areas of medicine will benefit from current technological advances. General practitioners, as an example. Many doctors choose this specialty today because they have a chance to make a long-term impact on someone's life. And it's true that GPs enjoy tremendous trust from their patients. But seeing someone only when they are sick makes it hard to prevent disease and ensure someone's long-term well-being. It's even harder to do this when waiting rooms are overflowing. You only have 15 minutes to diagnose the illness, design a therapy, and offer health advice. In the future, wearable sensors and devices that stream data to a doctor's smartphone will notify them whenever vital signs are acting up and provide them with all the data they need, wherever they are. These devices will also ensure doctors only treat patients who really need professional care, making it possible to offer simple treatment advice remotely. In turn, this will increase the time GPs have to treat and advise each patient, building trust and ensuring patients act on a doctor's advice. Smart algorithms will allow GPs to tap expert advice on their patients' conditions and act as a gatekeeper, connecting patients to other specialties. And these are just a few examples. So what about radiology? Well, already IBM's medical suite shows how artificial intelligence algorithms can scan hundreds of radiology units in seconds, doing the repetitive job of finding relevant or out-of-place phenomena that currently radiologists have to do daily. This technology won't replace this important specialty. Instead, radiologists will have time to supervise how the algorithm is doing, or to research and innovate, making the technology behind these devices even better. Their time will be much more productive rather than spent checking hundreds of X-rays a day. Ophthalmology will bring science fiction technologies to patients in the near future. Retinal implants might give vision back to those who have lost it, or even give humans supervision, augmenting what we can already do. In sports medicine and rehabilitation, the first forms of activity records from tech like Fitbits all focused on people who exercise regularly, but only provided basic insight into how they were behaving. Now, a new generation of devices tailored to professional athletes is hitting the market with apps providing detailed insights into movement patterns and force output in any movement. Sports medicine physicians will have concrete data to measure how athletes are improving. By the time these reach the mainstream public, sophisticated algorithms will be ready to analyze data from these devices and provide personalized suggestions to improve performance and speed up recovery. Similarly, video consoles from Xbox to Microsoft Kinect will offer a way of monitoring how a patient is doing from a distance by seeing their progress liquidly on a screen. In oncology, this specialty will pave the way for personalized medicine. Even now, oncologists customize therapies to a patient's genetic background and to their tumor's molecular marker. Cheaper genome sequencing and measuring blood biomarkers are speeding up this process, with companies like Grail working on fluid biopsies which could filter tumor cells from blood samples. Tumors could soon be diagnosed earlier and analyzed without costly surgery. Artificial intelligence could soon be used to help oncologists understand and even cure cancer. Already, IBM Watson obtains all the relevant information from millions of studies about a patient's case and makes suggestions for treatment plans most likely to work. In the meantime, patients are better informed about the disease thanks to social media communities of fellow patients. These signs all point to a bright future for oncology in partnership with new tech innovations. So what does this all point to? Well, my conclusion would be that, all in all, many jobs will be taken over by robots and automation in the coming years. But, at the same time, amazing opportunities will also emerge, especially in medicine. These will require physicians to acquire new skills and improve their existing ones. In my opinion, the majority of specialties will have more time for patients and better insight into disease.